I would just like to welcome everybody to this presentation. It's a COVID-19 update, particularly focusing on the Eastern region. The first time I did one of these events was some 18 months ago, and there's a lot that's changed in that space. So looking forward to some presentations by some of my fantastic colleagues. So just also thanking the Eastern Melbourne PHN for hosting and organising this event as well and acknowledging them. For those of you who don't know who I am, my name's Penny Gaskell. I'm a GP by background. I probably know most of you through my GP liaison role over the last 8 or 9 years, and recently I've been working as a executive clinical director and acting executive clinical director, and a lot of that work's been very much in the COVID space and working in the community. My colleagues today, so we're welcoming Dr. Iftar Ahmed, who's our GP, one of our COVID consultants, and Dr. Kara Novak, who's our medical lead for COVID at home and a general physician. So we look forward to hearing from those two. Just to flag with you too, the event is going to be recorded, so hopefully that's okay with all of you. But we are only keeping it live for probably a couple of weeks, and as I'm sure you're all very well aware, that things change extremely rapidly in the COVID space. So the information presented today is the current as of 6:32 today, and it may be outdated very quickly, as I'm sure you all understand. So just an acknowledgement of country, I'd like to acknowledge the Wurundjeri people and other people of the Kulin Nations on whose unceded lands our work in the community takes place, and respectfully acknowledge our ancestors and elders past, present and emerging. So the agenda today, we've only got an hour to spend with you. So I'm going to do a very brief run through of Health Pathways Melbourne and how that might assist you. Iftar's going to focus on the journey of the COVID positive patient. And what I think is interesting about the COVID space is a lot of us, it's very personal for a lot of us, most of us have had either COVID ourselves or family member or friends with COVID. So we've actually, a lot of us have been through that journey themselves, and from a personal experience, my son's had COVID, so I've been on the other end of what it looks like from a patient perspective. We're going to be very much focusing on the Eastern Health Services, and I'll come to that a little bit more in a moment. And Kara will be really focusing on the early COVID treatments and eligibility criteria. Very keen to answer any questions, but we'll keep those questions until the end of the presentation. So please use the Q&A box for those questions, and we'll come to that at the end as well. So Health Pathways, many of you would be familiar with Health Pathways, and as you can see, it's had a little bit of a revamp there. It looks really lovely and presentable and clean. It is obviously it's aimed at GPs. It's a single website with clinical and resource information, but really importantly, up-to-date referral information. And no more important than in COVID, our processes and referral pathways and what services we offer has changed I don't know how many times. Also important to note, Iftar's going to focus on the Eastern Health Pathways and how GPs and other clinicians can refer to us. It is important that you do review where your patient's postcode is. Patients are allocated to a COVID pathways teams according to where they live. And so as a GP, it's important, as with lots of other things, each different hospital has different processes and different pathways. So using Health Pathways as a resource is really, really important. And if you need information on how to get a username and password, the email address at the bottom is where you need to go to get that information. So this is just a summary of the suite of COVID-19 resources for you all. So we're obviously going to be focusing specifically on referrals in this space, but of course in general practice, all of those other items are absolutely relevant to each of you. So the learning objectives, you would have seen those when you signed on, but we're going to go through the journey of a COVID positive person in the Eastern region, also describing how Eastern Health can support those patients and how you can refer to us. And then Kara, as I mentioned, will talk about the early treatment options, provide a lot more information around that, and also specifically focusing on the eligibility criteria. So I'm very happy to welcome Dr. Iftar Ahmed. Now, Iftar is a GP who has been involved in pretty much every element of the COVID response over the last couple of years, and that includes anywhere from swabbing to vaccinating to now working with us in the COVID positive space. He was the medical lead for a non-for-profit vaccination program in the Inner East. And the last 4 months of that feels a lot longer than that, but for good reason. IFTA has been an integral part of our COVID pathways team, and of recent times the medical lead for our hospital in the home team. So we're very, very pleased to welcome Iftar to Eastern Health, but also very, very pleased to have him here today. So I'll hand over to you, Iftar.
Thank you, Penny, and thank you everyone for coming to this meeting after work. We all know that these days can be quite long days with COVID, so I really, really appreciate it. So what we're going to talk about to begin with is what Penny said, the journey of the COVID positive patient. And some of you might have actually experienced yourself. Be aware that what we're talking about is the current process. It is the ideal process. It doesn't always happen, but this is just a general overview of it. We're going to talk mostly about adults, as we are going to try and organize a few sessions in the future about pediatrics. So what we're seeing here is just this spectrum that we have of the care that we provide. So it goes from self-engagement all the way to high acuity care, which is hospital care. And in the middle, we've got the low, medium, and hospital in the home care. So we'll just go through each one of them, try and explain it, and try and explain how the patient might go between these cares. So it's always nice to have a case study to talk about. So this is a case study of a patient which we actually had. So this is Peter. He's a 20-year-old. He's a student. Recently moved from Sydney. He lives with his aunt at the moment, and he has no GP in the area he knows, and he developed flu-like symptoms the day before. For Peter, his journey begins by testing positive. He tested positive by a rat test. Something for you to be aware of. If a patient tests positive on a PCR, automatically all the information and data goes to the government, Department of Health, and then that's how patients get flagged. If a patient gets a rat, be aware that unless they report it by going online or by calling the 1-800 number, the Department of Health and us do not know about that. The reason why I'm stressing this is so important, because we actually had GPs calling us, telling us, look, I have a patient I'm quite worried about. They are day 4, day 5. No one actually contacted them. And on further questioning, we figure out that the patient had a rat and they never report it. If we don't know about it, there's not much that we can do. So always remember, when a patient calls you, tell you that they tested positive on a rat, ask them, have you reported it? The next part is after the patient gets flagged with the Department of Health, they will receive a text message. It's quite a generic text message in which provides them some information, as well as asks them to actually provide, like there's a link, and provide information in that link. That information is extremely important, as that will help the Department of Health decide, first of all, which health pathway that the patient will go on. So which health network. So for us, it's in the East. So any address in the East under our postcodes will come to us. This address, sometimes patients do get confused. They put address of their regular residence while actually isolating somewhere else. So it's quite important to make sure the patient does put their actual physical address they're going to stay in for the next 7 days of isolation. As well as it will ask them about other demographic information and medical history. Just remind the patients to please provide the best and most accurate information, as that will help them triage into a model of care, which we'll talk to in just one moment. Also be aware that it does take some time for this data to actually be passed on to us, especially during times of surge. It can take quite a while, so it can take from even up to 12 hours. Even we had patients which we only ended up contacting in the last surge on their day 6 or 7 of their illness. So just before they went out of isolation, which is not very helpful. So that's where we actually ask you guys to help us, as it is a team effort. We're here to support you. We're here to support the patients, but we also ask you guys to support us and support the patients as well. Because at the end of the day, we're all a team. So to continue the story of our patient, of Peter, his medical history is that he had 2 COVID vaccines. He has asthma. He was ventilating about twice a week. And he also has schizophrenia, which is aripiprazole once a month for. This, in the next 3 slides, what we're going to talk about is our model of care. You do not need to know it. We know it's quite long. It's just for you to an idea of how we triage our patients and how we decide in which pathway they might go under. So just to give you a bit of an idea. So what we've got the self-engaged, we've got the low, the medium, which is divided into our medium pathways, as well as HIF, as well as the high, which is more the hospital care. So the self-engaged are going to be the young and well who mostly just got COVID and they'll get over it. They're very low risk. We then have the low, which might not be able to engage as much or have very slight higher risk than the rest of the population. For example, if they're unvaccinated or have psychosocial risk factors. And then we have the medium, which are a bit higher risk patients. And then we have the intensive care, the HIF, in which are the patients which have moderate symptoms and we need to watch quite closely. This is just a list of our high-risk comorbidities. Again, you do not need to know it. You just need to be aware that we do have a list we go by, and that just helps us assess our patients. We then have a list of symptoms. So as you can see, we've got the mild, moderate, and severe breakdown of the symptoms, and that just helps us assess our patients and figure out what we should do, when we should escalate their care. Something you need to be aware of is that out of hours, patients can still be assessed. So what they do is that under certain pathways, which we'll touch on shortly, patients get a text message once a day in which it has a link in it, and they can put in their details of their symptoms, for example, shortness of breath, tiredness, lethargy, how much have they been drinking, have they been sleeping too much, and we've got an algorithm that will, depending on what they put in, will then put them on symptoms as mild, moderate, or severe. If the patient is mild, moderate, or severe out of hours, it will automatically be flagged for the virtual ED triage in the Northern, and they will try to assess the patient for us as well as for you guys. So you can tell the patient, look, if you're unwell, please make sure that you are using and reporting your symptoms, as well as can always call 000 or My Emergency Doctor, and there's a visual telehealth consult for the patient out of hours. So we do have services for that time when we are unable to help, as well as you guys are not able to help, because we don't expect anyone to do it 24/7. So what we're going to do now is just go through an overview of each pathway. So we've got the self-engaged pathway, which, as we say, is a very low-risk patients. The patient pretty much only gets a text with a number for nurse on call, and that depending on the history they gave us, and they're managed in the community, which in other words, we say it's all in your hands, because we assessed them and said, look, they're probably not going to get sick. They're going to be okay. Next one, we've got the low pathways. So these are the low-risk patients and mild symptoms. So every day, the patients will receive a text message, we just spoke of, and a clinician will assess them only if they are worried about their symptoms. So if we triage them and we said, look, today, Peter said that he has moderate or severe symptoms, therefore we need to ring him. And that is done by our lovely community health providers. So for us, it's each, which helps us with it. Things that you do need to be aware of is that, again, during surge times, we don't have the capacity to assess everyone. So we will tell the patients to contact and reach out to you guys so then we can help us as well. So it's all about help us so we can help you. And these patients get discharged on day 7 of their symptom, regardless of the symptoms. Automatically, they're out of isolation, they are discharged from our care. So for our history, we do have for our case, so Peter, he was allocated to low pathways depending on our algorithm. But he did start developing flare-up of his asthma due to COVID-19, which is something we're seeing very, very often. He's now needing to use ventilating 3 times a day. So that was flagged on our system as severe symptoms because he had shortness of breath. Our clinician reviewed them, escalated to one of our doctors, Peter was reviewed by one of the doctors, asthma education was provided, a specialist was sent, and he was moved to medium pathway because now he was deemed a bit of a higher risk and was set to be reviewed for the next day. So what do we offer in the medium pathway? So that's for the medium risk patients with mild symptoms. So again, we have the same text. It's exactly the same text sent to this patient. But this time, the clinician will call the patient every 2 to 3 days, depending again on the surge, on the availability for clinicians, and how many patients reviews are needed. And of course, we will try and review them more frequently if required. With regards to discharge from a service, this time it's until we discharge them automatically on day 14, even though they actually are able to come out of isolation on day 7. So it is quite confusing for patients because they say, look, I'm out of isolation, why are you still calling me? So it's these 7 days of just this gray zone that we need to be aware of. So Peter was reviewed the next day, but this time he actually feels that he had content tightness in his chest. He's now using Ventolin every 3 hours, and his saturation is 97%, his heart is 100. So what the doctors did was prescribe oral prednisolone, he was started on inhaled corticosteroids, and it was escalated to COVID-HIF, as now he actually had the moderate to severe, more moderate symptoms that we just wanted to keep a close eye on. So what do we offer with COVID-HIF, which is the moderate symptoms? Here we have each patient receiving a call from a doctor or senior nursing staff, usually every day. For the patients we're truly worried about, we've even in the past done twice daily, just to make sure they are all right. And this time, instead of actually doing it as a specific day, we just discharge them when they are not requiring the high level of care, or sometimes if it's past day 14, which we are seeing at times, we're saying, look, they're not infectious, they probably need to have reviewed in person, so we hand over to you guys to actually see them in your clinic in person. Something to be very aware of is that you are not able to bill Medicare when a patient's under HIF. So that's only if the patient under hospital and home, because it is technically hospital, we cannot do the double dipping. The Medicare does not allow it. If the patient is under low, very low, or medium pathways, that's absolutely fine. There's no issue. It's only if it's under HIF, and we do stress to patient as well. Look, we're the one providing. You can only see your GP after we discharge you from our care. We then, about high care, is the severe symptoms, is when it's only provided at Box Hill hospitals. That's where we have our COVID ward. So that's 9.1 and 9.2 at the moment, in wards in which we have our COVID positive patients. And that's when we send the patients we're truly concerned about that cannot be managed in the community. So as you can see, it is a spectrum. So for example, Peter, he moved from low to medium to hospital in the home. And when he was well enough, we moved him back to medium pathways. So patients can fluctuate between this level of care, and the higher the level, the more interactions we have with the patients. And we do ask you guys to be involved mostly in the low and medium pathways, or on patients we discharge from hospital in the home, and especially the self-engagement. So the next thing that we're going to talk about is what services does Eastern Health provide to COVID positive patients. So before we do that, let's just touch on the roles that we have at the moment. So we've got at the moment 3 roles of doctors. We've got the COVID positive pathways consultant, which is in charge of the low and medium pathways. We've got the COVID-HIF medical lead, which is in charge of the COVID-HIF. And we've got the COVID-HIF treatment medical lead, which is in charge of the COVID early treatments. So it all makes sense, all the names. So what are our goals? Our goals are to keep the patients out of hospital, keep patients in their own homes, and of course, assist you guys with patient care. So we're just trying to build an infrastructure and processes to try and help you with the care provided to patients, because again, with all the surges, it gets overwhelming for everyone. So we're just trying to work together to provide the best care to patients, but we can't do it alone, which is why we need all of you guys. So how can we achieve these goals? Using all of those 5 different things that we offer, and we will go one by one and explain what exactly we mean. So the general advice to GPs and monitoring. You need to be aware that no question is a silly question, especially 4 months ago when the numbers were going up. A lot of you guys were not very confident in managing COVID positive patients, which that has changed quite a lot, which is really, really nice to see. So the question we're starting to get now are more tailored towards COVID positive patients, which requiring early treatment, and not just specific about, look, I've got a COVID patient, what do I do? So that's really impressive to see it from all of you guys. And this advice is available every single day, 7 days a week, between 8:30 and 4 o'clock. And the doctor will always be able to answer your questions. And of course, if you need a pulse oximeter organized for your patient, you can let us know, you can organize it, but that does depend on certain eligibility criteria and if we deem it necessary. So initially with Delta, we thought it was quite important. Now with Omicron, it's probably not as much, and that will probably change soon. As well as we only send pulse oximeters to our patients at the moment, which are the medium pathways to fit these criteria, as well as the HIF patients. So just be aware that sometimes we might say, look, we don't think we really need to actually send pulse oximeters for this patient. It's all right just monitoring them with telehealth. So if you want to contact any of these reasons, you're going to call the COVID positive pathway consultant, and that is the right contact. And at the end, I will have a summary of all these numbers. We have the clinical reviews that we're providing. So these are patients who are unwell with moderate symptoms, who need extra care, but not enough for hospital escalation. And that's our HIF patients mostly, or as well if they're moderate and we're trying to figure out what is the best pathway for them. For clinical advice for these patients, or if you are concerned about them, we have a doctor available between 8 o'clock and 5:30, and that's every single day of the week. And again, the best contact person is the COVID positive pathway consultant. So we are trying to make it simple for all of you guys, one number for these kind of concerns. What we also remember was that Peter, in our case, was living with his aunt. His aunt is 50-year-old. She lives with Peter, as we said, and she returned a positive rat. Something that Peter did tell us about Aunt May is that Aunt May has MS and is on ocrelizumab, which is one of the beta-depleting therapies, which puts Aunt May at a high risk of severe COVID infection. And that is when it comes to what else we can offer. So COVID early treatment referrals, which Kara is going to go into a lot more detail about, but I'm just going to quickly touch on. And that can be made through this email, which all this information is on Health Pathways, as well as on our Eastern Health website. We will prioritize referrals over the patients from our algorithm, which we do try and flag patients which are immunosuppressed. And if the referral is urgent due to the timing, so for example, if it's a medication, it can only be given the first 5 days, it is day 4 or day 5, please call us. Or if you've got any questions about COVID early treatments, we're always very, very happy to answer questions. And the person to contact for that is the COVID early treatment medical lead. So again, all the numbers will be in my last slide. Something that we're just going to quickly touch on in regards to COVID early treatment is the inhaled corticosteroids. So at the moment, there are 2 options. We've got the budesonide as well as the ciclesonide. And these are medications for patients which are deemed higher risk of severe COVID. So that's the patient age 65 or 50 plus any of the risk factors. And we do know from especially the Principles trial is that use of inhaled corticosteroids can reduce the number of days which patients are unwell, as much reduce the presentations to hospital. And it is quite a cheap medication, low risk as well. So that's just something to consider. Because it is such an easy prescription to provide to patients, but we have so many, what we're doing is we're actually sending a mass text message to patients. I would actually love for all of you guys to comment in the chat if you actually had patients rocking up asking for budesonide. So what we're doing is we're just trying to figure out which patients may be eligible for it. We're sending them a message asking them to come see you to actually prescribe it or initially assess if they might be eligible. Because at the end of the day, it is a wide net approach, so they might not be eligible for it, but just flagging it with them. If you want to know a bit more information about this, you can always go on the Health Pathways or the National COVID-19 Clinical Evidence Task Force, which has the most up-to-date guidelines, because it's just trying to briefly touch on it. It's not the full eligibility criteria as well, as there is exclusion criteria that need to be aware of. So the further care that we provide as well is that during his care, Peter informed the team that both him and his girlfriend MJ were due to their aripiprazole depot injection. At the time, they were still COVID positive. They were infectious period, so they couldn't actually go in to find a GP who will be able to provide it. So what we can provide patients is non-COVID related care during the time of isolation. So all of these lists on the right are things that we actually been able to offer to patients over the last couple of months. months. So we've done IV antibiotics for cellulitis, regular blood test, INR monitoring, Clexane bridging, antipsychotic depot injection, just a repeater, as well as recently blood product transfusions. So if you got any patients who might be needing that care, this is the number for you to contact. So that's the COVID HIV medical lead, and we'll try and organize it for your patient to help you. And as we promised, this is just a quick list in which has all the numbers. If you want to quickly take a picture of it, that'll be wonderful. And that will be the end of me. And I'll happily hand over back to Penny, who can introduce Cara.
So my name's Cara Novak. I'm a general physician by background, and I've had some experience working for the Northeast Public Health Unit as well before I started this role as a medical lead for COVID care at home. I also have special interest in looking after patients with complex multimorbid medical conditions, as well as medical education. But in the last 5 months, I've been doing mostly COVID work, which has been quite interesting, quite exciting with all the new treatments coming out in that space. So I'll briefly discuss what early treatment options we do have available. This is not exhaustive by any means. We could probably do an hour on each of the medications if we wanted to, but I'll just quickly go through them and then explain how to refer patients and who might be eligible for these treatments. So the first treatment that we have available to us, most people will have heard of, as it was one of the earlier treatments made available in November, is sotrovimab. This is a monoclonal antibody against the spike protein of the pan-sarbecovirus. The evidence base for this medication came from the Common ICE trial that was released in 2021, which looked at unvaccinated patients with one or more risk factor for development of severe COVID illness. The trial was recruited between August 2020 and March 2021, so it was during a period of time where it was majority alpha variant, possibly some delta, so not the same variant as we're seeing now. And the primary endpoint of this study was looking at hospitalization and death within 1 month of the infusion. In terms of the outcomes, the event rate in the sotrovimab group was 1% versus placebo, which was 7%, and there was an 85% risk reduction in hospitalization or death. What we have found with our experience of giving sotrovimab since November is that it's very well tolerated, minimal side effects, no absolute contraindications, and it was pretty much our main armor during the last wave of Omicron BA1. We were giving about 120 infusions a month of this to prevent admission for patients that were high risk. Unfortunately, it is reported not to be effective against Omicron BA2, which is the new subvariant of Omicron and is now thought to be the dominant variant, especially in the eastern suburbs of Melbourne. So it is no longer being used by us, except in select cases, as it's likely to not be effective for most of our patients. The other issue is we have limited supply left in the state, and at this stage are not receiving any more supply of this medication until further notice. So at the moment, while it's been great while it lasted, we aren't really looking at using sotrovimab anymore. The new kid on the block, which is our preferred agent now, is Paxlovid, which is a combination oral antiviral treatment. It's a combination of a new protease enzyme inhibitor called nirmatrelvir, and this has been specifically developed for the treatment of COVID. It reduces viral load by interfering with the viral replication cycle. And the other element of this drug is ritonavir, which is a very old protease inhibitor that's been used for HIV care. The reason that it has no activity against COVID, but the reason that it's been incorporated into this medication is that it's a potent CYP3A4 inhibitor, and it increases the plasma concentration of the nirmatrelvir, which means we can use a lower dose of that agent to treat patients. The study that was released this year, the EPIC-HR trial, which was released in 2022 this year, was in unvaccinated outpatients greater than 18 years with at least one risk factor. Again, recruitment was August to December last year, which was not when Omicron was around. It was mostly Delta. And as you can see, the breakdown of the patients that were recruited were predominantly obese patients or overweight patients, smokers, or those with hypertension. No immunosuppressed patients or cancer patients, very minimal cancer patients, which is actually the main group we're targeting with these therapies. The other thing to note is all these trials have been on unvaccinated patients, not fully vaccinated immunosuppressed patients or partially vaccinated patients. So we're kind of extrapolating that the end point is similar for those groups. The primary endpoint for the study, again, was hospitalization or death within a month. And the event rate in the Paxlovid group for patients treated within 5 days of symptoms is 0.77% versus 6.31% in placebo. So again, a very similar to sotrovimab, an 87.8% risk reduction. So the main side effects of Paxlovid, it's not as straightforward as sotrovimab in terms of side effect profile and prescribing. The main side effects are diarrhea, vomiting, dysgeusia, and headache. Interestingly, IFTA has told me that 100% of our patients that we have prescribed Paxlovid to have had dysgeusia, even though that's not what it's quoted on the drug information. Some less common side effects are myalgia and hypertension. It's a very high pill burden, so patients need to take 3 tablets twice a day for 5 days. So patients taking this need to be able to manage their medication or have someone at home that can manage their medication. And they need to be able to swallow tablets as well. So if they've got any swallowing difficulties, this would be an issue for them. We have to assess a patient's renal function before prescribing because we need to renally adjust the dose for patients that have an eGFR between 30 and 60. Some patients may need bloods prior to commencing if clinically indicated, which makes it a bit tricky when they've got COVID in isolation. There's also an extensive list of drug interactions due to the CYP3A4 inhibition. So we need to work closely with pharmacy and do an extensive medication history for most patients that get this. And that can sometimes be very time consuming. It can take up to an hour to do that history. And sometimes it involves a lot of liaising with our pharmacists to either adjust patients' regular medications while they are on this or withhold medications or potentially not prescribe this agent at all. The contraindications, it can't be used in patients with an eGFR less than 30 or who are on dialysis, or in those with the equivalent of Child's QC, cirrhosis, or severe liver dysfunction. The benefits of this, though, is it's not dependent on the spike protein mutation, so it should be effective for future variants, and it is thought to be effective against BA2. It is oral, so it doesn't require patients coming in for an infusion. We can send the medication out to the patient and just monitor on the phone while they take it at home. So it is quite convenient in that respect as well. The other oral antiviral agent that's available is molnupiravir. So this is a prodrug that has broad antiviral activity against RNA viruses. It causes viral mutations and lethal mutagenesis. So it ultimately renders the virus non-infectious and unable to replicate. The evidence base for this is from the Move Out trial, which was released last year, and a similar cohort of unvaccinated patients in recruitment through May to October last year. And again, a similar risk profile with majority of patients being that overweight group and essentially no immunosuppressed or cancer patients. The primary endpoint is the same as the other trials. However, this medication is shown to be less effective than both sotrovimab or Paxlovid. So there was a 30% risk reduction in hospitalization and death. And the interesting thing, or the thing to note, is that in the interim analysis released by the release of this trial, they did initially show a 70% risk reduction, and then the final study showed a 30%. So there is a big disparity there, and it's unclear why that changed, which obviously raises some concerns about the power or, whether this is actually accurate. There are also some subgroups that showed no benefit from this agent. So those with previous COVID infection had no benefit with molnupiravir. Those with a low baseline viral load, and interestingly, those with type 2 diabetes or type 1 diabetes had no benefit with molnupiravir, which is a large proportion of patients that would be eligible for these treatments. The benefits is it's got a high barrier to development of resistance, minimal side effect profile, and it's on the PBS, so it's easy to prescribe, and GPs can prescribe it, and we can prescribe it to patients in aged care facilities. So they don't need to necessarily be referred to us to be prescribed this medication, but if we want to consider them for other medications, they do need to be referred to us before we decide to give them this agent instead. Patients should be counselled on contraception is the main thing to counsel patients on. Consideration should be given to whether a patient would reliably use contraception as well. So if you don't think the patient would necessarily use contraception, then it might not be the best agent for them. The advice is that women who are sexually active and of childbearing years should use contraception until at least 4 days after the final dose. And for men, it's for 3 months after the final dose, which I guess you have to ask, once a patient is recovered from COVID and finished their treatment, are they going to continue using contraception for 3 months after they've been treated? Are they going to remember to do that? There's also this theoretical risk that it would be metabolized by the human host cell and lead to DNA mutations. There's no good evidence for or against this. There's been a few trials that have been quite equivocal in outcome. So this is something that we have no longitudinal data and really don't know what the longitudinal outcomes would be for using this treatment. The third treatment we have that has been approved, but is not necessarily widely available yet due to logistical difficulties, is remdesivir. So this has been widely used in hospital for inpatients with COVID for some time now, and we know it's very effective. It inhibits viral replication by terminating RNA transcription prematurely. And recently, while there's a number of studies already based on inpatients in hospital, recently there's been a new study released called the Pine Tree study that was looking at outpatients with early COVID and again, prevention of deterioration. Again, similar patient cohort and similar recruitment time and very few immunosuppressed patients or cancer patients in this group, but a similar event rate as Paxlovid. So those patients receiving remdesivir had an 87% risk reduction, hospitalisation or death within a month of treatment. The side effects of remdesivir are nausea. They can get elevated ALT or AST, increased prothrombin time without an elevation of their INR, and there is a higher incidence of hypersensitivity reactions with this medication. The difficulty with remdesivir is it's an IV infusion and it needs to be given over 3 days. So patients need to have an IV infusion 3 days in a row. The infusion takes half an hour or anywhere from 30 minutes to 60 minutes, and the patient's required to be observed for at least an hour after the infusion. So as you can see, it's very resource intensive and we have limited capacity to be able to offer this due to staffing and space concerns, and also patients being able to come into our outpatient treatment setting 3 days in a row while they have COVID. We can commence treatment within 7 days of symptoms for remdesivir, which, unlike the other agents, is 5 days of symptoms. There is a theoretical risk of renal and hepatic toxicity due to this component in the medication, the SBECD component. However, there's been observational studies and many case studies on patients with chronic kidney disease or on dialysis, and there's no difference in the incidence of AKI or adverse effects in patients with a low GFR below 30 versus patients with GFR above 30. So it's really just a theoretical risk rather than a proven evidence-based risk. It can also be given in pregnancy and in children. So now that sotrovimab is not effective anymore, this is really the only medication we have available to us that will be able to be used in pregnant women and children between the ages of 12 and 18. So that's a bit of a summary of what I've just gone through. As you can see, sotrovimab is out now because it's not effective for BA2, but Paxlovid and remdesivir are both very effective agents, and molnupiravir is probably inferior to those agents, but is more widely available because it's available on the PBS. It's easier to prescribe and has less resource intensive and has a lower risk profile. In terms of symptom windows, Paxlovid and molnupiravir are both within 5 days of symptoms, with remdesivir within 7 days of symptoms. Remdes is the only one now that will work that is we can give to children and pregnant women. Molnupiravir is the only one, arguably, that we can give to patients with renal failure or who are on dialysis, although theoretical, possibly we could give remdesivir if we're giving it off-label based on these theoretical concerns without actual evidence for them. And again, molnupiravir doesn't have any contraindications, whereas Remdes and Paxlovid do. So while Paxlovid and Remdes are the better agents at this stage in time, molnupiravir is obviously the easier one to prescribe. In terms of patients that are eligible, so the hospital and where we're working, we have to go through the National Stockpile Access, so we have to complete these forms for all patients, so they need to meet these eligibility criteria. So we have to know when their symptom onset was and make sure they're within the treatment window. We have to look at the patient groups, so whether they're immunosuppressed or unvaccinated and which age group they are in, and also lower priority is partially vaccinated patients, and also those that are pregnant or Aboriginal Torres Strait Islander can also be eligible depending on their comorbidities and their vaccination status. In terms of which immunosuppressive conditions we consider, the patient needs to be significantly immunosuppressed, and this is the guidelines we have, but as you can see at the bottom, it does say other significantly immunocompromising conditions, which does leave it open to interpretation. We do follow guidelines from the CDC as well as the ATAGI guidelines around vaccination to kind of help guide us who we think is significantly immunosuppressed. But we are more than happy to discuss any patient that you think might be immunosuppressed and could qualify for any of these treatments. The other thing to consider is the comorbidities. So some patients that are partially vaccinated but with comorbidities might be eligible, and this is the list that we go off. This is all available on the Department of Health website as well. And then the other thing to be aware of is because the large number of patients now that are eligible, we do need to prioritise certain groups of patients. And part of this is out of our control. We are directed by the Department of Health who to prioritise. So it's mainly that immunosuppressed group that are greater than 12 years old, and also the unvaccinated population that are over 80 years old that we're prioritising at the moment. In the priority 2 and 3 categories, you can see once we get to 2, 3 and 4 categories, once we get to those groups, we're looking at many, many more patients, and we are not being able to reach all of those patients. Sometimes if patients are directly referred, we can get to priority 2 patients, but we're definitely not reaching the priority 3 and 4 patients due to just time limitations and capacity. So potentially any patients that you have that are in the priority 3 and 4 group, certainly call us and discuss with us, but we may recommend to just prescribe molnupiravir based on the PBS criteria. In terms of how to refer to us, we have an email address which is monitored every day, 7 days a week. And we also have a referral form that's available. So you could just get this referral form and fill that out and send it to us, and then we can assess whether the patient is eligible and triage them based on their priority as well. If you have an urgent patient, so say they're day 4 or day 5 of symptoms and we need to consider giving them treatment that day, you can phone the early treatment doctor on this number, but we ask you to please just reserve it for very urgent referrals. Our team of doctors, nurses and pharmacists will assess the patients and make the decision on what we think is the best treatment available. And we may, as I said, may advise you as the GP to prescribe molnupiravir if we don't think they would be a priority for Paxlovid or remdesivir. Unfortunately, as I said, we won't probably get to priority 3 or 4 patients, and we do anticipate we'll not be able to offer early treatment to all patients. So that's where, that molnupiravir being on the PBS does become helpful because you're able to assist us with those lower priority patients. That is all my slides. I'm sorry I went quickly. I was just mindful of the time and leaving some time for questions. So I'll stop sharing my screen.
So thank you so much. And Cara, I hope you introduced yourself, but I just want to acknowledge the work that Cara's done. So Cara's a general physician who's been our medical lead for COVID at home, including HIP and pathways. And as you can see, this work that she's done is only the last couple of months. And so a tremendous amount of work done. So thank you, Cara, and thank you to Iftar as well. I had trouble with my internet, but I did see a question about With probably more relation, Iftar, to your comment around HIF, and does HIF communicate to GPs because of billing? And yes, they do. In theory, they should be sending GPs an admission and discharge letter so that you are aware of that. So that's one of the questions. I think the next one is for you. Can you tell us, I can't even say the name of some of these medications. Can you see that question? Evusheld will fit into these pathways?
Evusheld is another medication. It's a monoclonal, or it's a combined monoclonal antibody. It's tixagevimab and silgavimab. So this is a new agent that is in the pipeline and potentially will be in Australia within the week, but maybe not. We don't know for sure. And it's going to be used, at the moment, it's been approved as pre-exposure prophylaxis. So this will be for a very select group of high-risk patients, mostly transplant, stem cell transplant, heart transplant, but we don't have the official criteria for patients. But high-risk patients that are at risk if they do contract COVID but don't currently have COVID. It's 2 IM injections, one of the tixagevimab and one of the silgavimab, and it has about an over an 80-day half-life and has been shown to reduce the risk of developing symptomatic COVID by over 80% in these high-risk patients. So I think at the moment, there's only going to be very limited doses available, and it will only be available to that select criteria patient, which will be governed by the department. There's still no guidelines of who will be giving this, whether it's GPs or whether it's patient specialists. It most likely won't be in our patch, given that these patients don't actually have COVID, so they're not on COVID pathways. But there may be a point in time, and I certainly have heard that they are looking at potentially giving it IV or they're applying to give it IV for early treatment. So that might be something that we see in the future if the TGA does approve that. I hope that answers the question.
Thank you, Cara. Thank you. Any other questions? There's lots of changes, as I said, in this space. Just to give you a little bit of background, Eastern Health, I think in January, our numbers in our region peaked at around 16,000 active cases. And I think I'm probably making the numbers up, but we're well over 100,000, even probably many hundreds of thousands of cases that have come through in the last 2 years. So it's an extraordinary effort by everybody working in healthcare. The other thing I think we're pretty keen on hearing from your team, from you guys out there is, how else can we support you? What other education can we provide to you, both COVID and of course non-COVID, because that's equally as important. So just keen to hear in the chat or filling in the sheet at the end. So we're really keen to the team. The other thing I think is important is Iftar, as I mentioned, is a GP, and aside from Cara, I think the rest of the team are GPs. So I think that's been just fantastic to have a team of GPs with a broad knowledge base that are upskilled in this area and really know how to communicate and work with our GP partners, which has been fantastic. And is quite unique, I think, too, in this model of care as well. So any other questions that people have? Now's the time to ask them. And I'm still having internet problems, so if I've missed one, I do apologise. So a question from Wendy. Can you provide information on managing patients with prolonged symptoms, i.e. ongoing severe fatigue, frequent tachycardia, weeks after COVID infection? Is that one for you, Cara?
Is it for me? So we really deal with the acute illness. In terms of long COVID, I know there is work. We don't have a long COVID service at this stage. It's something that we are looking into, but is not off the ground at this point. And I know most of the health networks probably don't have a long COVID service. Most of it is supportive care. So it's about rehabilitation, physio, pulmonary rehab, but unfortunately there's no clear services available to help these patients at this stage. Hopefully this is something that we do see in the future and we do have support for, but it is really just supportive and GP management for that time period.
Yep. And I'll certainly communicate that as soon as we do develop. So we are working very strongly on long COVID because of those huge numbers, as I mentioned before. So we are, and I'll communicate that out when we develop it. There's also the long COVID resources available in Health Pathways, which we would put together with some of our rehab consultants as well. So it's worth having a look at those resources. So a question from Lisa Yoffel: what happens when with billing patients if they want telehealth and have not been to our clinic? So I don't know that I can answer that one. Is that a PHN question? Is that something that you can assist with, Kathy? Or is that something we come back to?
Yeah, there might be something we come back to. Yeah.
Yep. Thank you. And from Denise, so I couldn't see the earlier question, Denise. Is IFTA able to answer my question I posed earlier?
I can see the earlier question if you want me to read
Thank
it.
you. I'm having trouble.
There seems to be 3 teams, Northern Health, Eastern Health and each, who provide telehealth on-call services. Can you clarify is this the same as New South Wales Health, Cavalry Health, who provide nurse triage phone service to COVID patients? I can let Iftar answer that.
Thank you, Cara. So in regards to what's happening in New South Wales, I'm not sure. Unfortunately, I don't work in COVID field in New South Wales, so I'm not sure what kind of process they do. But the way that we structure is that we do have 3 services, just that the Northern Health is more in charge for patients out of hours. That's the virtual AD, and they do care of majority of the Melbourne region. For us, what we have, we've got Health Direct, we've got each, and we've got our team. It does change depending on the surge of what type of care they provide, which patients and which pathways they take. So for example, at the moment, we each is taking the low pathway patients as well as the pediatric patients, while we're doing the medium pathways and then Health Direct just does the initial triage. So if you remember about the text messages, the first text message, then the patient is being triaged, but depending on the answers, by the Health Direct team. And then again, the Northern is just an out-of-hours service. Does that answer your question, Denise?
So Denise has said thank you. So we have a response to Lisa's question. We believe Medicare allows an exemption to the 12-month rules if patients have to isolate. So I hope that. So we have a question. We get patients that think they have severe COVID vaccine reactions, but not a true allergy. Can you suggest where we can get advice, please, as to their next COVID vaccine? Is that something for you, Iftar, with your vaccine hat on?
Absolutely. So your point of contact will be your VIC/CIS clinic. So that can be found just if you go to the Victorian.
I'll pop it in the chat. I'll pop the link in the chat.
Yeah, and they are the people to actually discuss that, and they'll be able to actually help you assess the patient and provide proper advice depending on the history, or they'll say, look, we don't think that the patient has any severe reaction, or if depending on the history, they say, look, we're just going to contact the patient ourselves and assess if they need to come in to get a further assessment or not. At the moment, I believe it is an online referral form to be done.
I don't think there's any other questions coming up at the moment. And it's just about the end of the webinar anyway. So I'd like to say a huge thank you to Eastern Health, Cara and Ifta, and also Penny and people behind the scenes running this webinar. There will be a survey that you'll send immediately upon closing this, and we'd really appreciate it if you could fill that in. Thank you, everyone. Have a good night.